It's a pleasure to be with you. The title of this talk is Cryptosporidiosis and Global Health. There are no disclosures for this presentation. Objectives include review the concept of DALYs as it relates to Cryptosporidiosis, review the Cryptosporidium life cycle, discuss the clinical manifestations, diagnosis, and treatment of cryptosporidiosis, and review community and personal control measures. This table presents the global burden of major parasitic diseases. The global burden order is determined by their DALYs impact in millions. This session will focus on cryptosporidiosis, with a disability-adjusted life year or daily impact of 8.4 million. Cryptosporidiosis is estimated to cause 276 million new cases and result in 100,000 deaths per year. Let's take a few minutes to review the concept of DALYs. The disability-adjusted life year or DALY was first used in 1993 in the World Development Report of the World Bank. A detailed discussion of how DALYs are calculated is beyond the scope of this session. A DALY is a health gap measure. DALY is a measure of overall disease burden expressed as the cumulative number of years lost due to ill health, disability, or early death. The formula for DALY equals YLD, or years lived with disability, plus YLL, or years of life lost. The DALY relies on an acceptance that the most appropriate measure of the effects of chronic illness is time, both time lost due to premature death and time spent disabled by disease. The sum of these DALYs across the population, or the burden of disease, can be thought of as a measurement of the gap between current health status and an ideal health situation where the entire population lives to an advanced age free of disease and disability. Cryptosporidiosis is caused by Cryptosporidium, a protozoa organism found worldwide that primarily causes intestinal diseases. Cryptosporidiosis is often referred to as crypto, but should not be confused with cryptococcosis caused by the fungal organism Cryptococcus, which causes primarily pulmonary disease. Cryptosporidium is one of the most widespread intestinal parasites and a common cause of diarrhea. Cryptosporidium can cause severe diarrhea in immunocompromised people and young children. Cryptosporidiosis was one of the initial defining illnesses for HIV/AIDS in the early 1980s. A review of 46 studies of chronic diarrhea in people living with HIV/AIDS in low-resource settings identified Cryptosporidium as the most common waterborne pathogen associated with chronic diarrhea and its increased risk of mortality. Most global cases of HIV/AIDS are in sub-Saharan Africa, the region of the world that also ranks last in sanitation coverage and next to last in safe drinking water coverage. Cryptosporidiosis not only impacts low-resource countries. In 1993 in Milwaukee, Wisconsin, a Cryptosporidium outbreak resulted in 400,000 infections and 50 deaths. A global enteric multi-center study found that Cryptosporidium is a major contributor to diarrhea in infants and toddlers in 7 countries in Africa and Asia, and associated with relatively high case fatality rates and nutritional stunting. Extensive outbreaks are associated with contaminated drinking and recreational water. Cryptosporidium is the leading cause of recreational water-associated outbreaks in the United States. Cryptosporidium species are oocyte-forming coccidian protozoa. There are two primary Cryptosporidium species that infect humans, Cryptosporidium hominis and parvum. Cryptosporidium hominis predominantly infects humans. Cryptosporidium parvum also infects humans, but can also infect other mammals. Cattle are a major host for Cryptosporidium parvum. Cryptosporidium has been detected in raw or unpasteurized milk or milk products, explaining why pre-weaned calves are commonly infected. This slide shows a simplified diagram of the Cryptosporidium life cycle. Infectious thick-walled oocysts are excreted in the feces of infected humans or other infected mammals. These oocysts can contaminate water and food sources through poor sanitation practices and inadequate water treatment. Infectious oocysts are ingested by humans and other mammal hosts through contaminated water or food and establish infection in the small bowel of the host, completing the life cycle. As diagrammed, hosts can auto-infect themselves via thin-walled oocysts. Thin-walled oocysts can exist in the host, causing auto-infection, while the thick-walled oocyst is shed in the environment. Cryptosporidium is primarily spread through the fecal-oral route, often through contaminated water. Recent evidence suggests that it can also be transmitted via fomites and respiratory secretions. This shows the life cycle of Cryptosporidium in a mammal host. There is an asexual and sexual cycle. When thin or thick-walled oocysts exist, sporozoites emerge. These sporozoites attach to the mucosal cells of the distal small intestine, starting the asexual cycle of the parasite. The attached sporozoite transforms sequentially into a trophozoite, type 1 meront, and merozoites that attach to mucosal cells, becoming trophozoites, expanding the number of cells that are infected. This asexual cycle continues as the infection progresses. This microscopic specimen demonstrates multiple Cryptosporidium parasites attached to distal small bowel mucosal cells. Merozoites can convert into type 2 meronts and enter a sexual cycle. These type 2 meronts can in turn develop into merozoites that become undifferentiated gamonts that subsequently differentiate into either microgamonts that become microgametes or macrogamonts. The merging of these microgametes and microgamonts creates a zygote that can become a thick-walled oocyst that's excreted via feces into the environment, or a thin-walled oocyst that can cause auto-infection in the host. These thick and thin-walled oocysts exist in the host, releasing sporozoites that can start the asexual cycle of Cryptosporidium. Because Cryptosporidium oocysts are extremely chlorine tolerant, multi-step treatment processes are required to remove or inactivate oocysts by filtering or ultraviolet light for drinking water supplies. So chlorination of water is not adequate to remove Cryptosporidium oocysts from drinking water supplies. These added treatment steps of filtering and ultraviolet irradiation of water creates problems for resource-challenged areas worldwide. Cryptosporidium infections can be asymptomatic. but frequently present with non-bloody, watery diarrhea, which is the most common symptom and sign of cryptosporidiosis. Other symptoms and signs include abdominal cramps, fatigue, fever, vomiting, anorexia, and weight loss. In infected individuals who are immunocompetent and children, diarrhea is usually self-limited, often lasting 2 to 3 weeks. Cases are most frequently reported in children 1 to 4 years old, followed by those 5 to 9 years old. Immunocompromised hosts, like children who have received solid organ transplants and those infected with HIV/AIDS, may have severe diarrhea lasting weeks to months, resulting in malnutrition, wasting, and death. Cryptosporidiosis should be considered in any solid organ transplant or HIV/AIDS patient with diarrhea. The incubation period for cryptosporidiosis is generally 3 to 14 days. Recurrence of symptoms after symptom resolution is frequent. In immunocompetent humans, oocyst shedding usually ceases within 2 weeks after resolution of symptoms. So infected immunocompetent humans may shed infectious oocysts for 4 to 5 weeks, including the 2 to 3 weeks when symptomatic and continuing for 2 weeks post-resolution of symptoms. In immunocompromised hosts, oocyst shedding can continue for months. Diagnosis of cryptosporidiosis is made by the examination of stool samples. Because oocyst shedding is intermittent, detection of Cryptosporidium can be difficult, so patients may be asked to submit several stool samples over several days. The Red Book recommends 3 specimens from 3 different days. Most often, stool specimens are examined microscopically using different techniques, including acid-fast staining, as pictured, direct fluorescent antibody DFA, and or enzyme immunoassays EIA for detection of Cryptosporidium antigens. Molecular methods like polymerase chain reaction PCR are increasingly used in reference diagnostic labs, since they can be used to not only identify Cryptosporidium generally, but also identify the Cryptosporidium species, for example, Cryptosporidium hominis or parvum, causing the infection. Tests for Cryptosporidium are not routinely done in most laboratories unless specifically requested. Let's spend a few minutes talking about treatment of cryptosporidiosis. Medication dosing and adverse reaction details are complex and beyond the scope of this session. For more dosing information, refer to references listed on this slide: the Red Book, Report of the Committee on Infectious Diseases, American Academy of Pediatrics, and the NIH and CDC Cryptosporidiosis Treatment Guidelines. Treatment consists of 1, supportive care to prevent dehydration and its complications, and 2, medications. Most people who have healthy immune systems will recover without treatment. Diarrhea can be managed by drinking plenty of fluids to prevent dehydration. People who are in poor health or who have weakened immune systems are at higher risk for more severe and prolonged illness. Young children and pregnant women may be more susceptible to dehydration resulting from diarrhea. Rapid loss of fluids from diarrhea may be especially life-threatening to babies. Therefore, parents should talk to their healthcare providers about fluid replacement therapy options for infants. Anti-diarrheal medicine may help slow down diarrhea, but a healthcare provider should be consulted before such medicine is taken. A 3-day course of nitazoxanide has been used for the treatment of diarrhea caused by Cryptosporidium in persons 1 year old and older with healthy immune systems and those with HIV/AIDS. A prolonged course of greater than 14 days has been used for solid organ transplant patients. Given the seriousness of this infection in immunocompromised patients, including those with HIV/AIDS, nitazoxanide should be considered. However, the effectiveness of nitazoxanide in immunosuppressed individuals is unclear. For infected individuals with HIV/AIDS, antiretroviral therapy that improves their immune status will also decrease or eliminate symptoms of cryptosporidiosis. However, even if symptoms disappear, cryptosporidiosis is often not curable in these patients, and the symptoms may return if the immune status worsens. Paromomycin with or without azithromycin might be effective, though there is limited data regarding efficacy of these medications. Control measures can be divided into two major categories: community measures and personal measures. Community measures include human fecal waste control and provision of safe and protected water supplies. Human fecal waste control includes adequate community sanitation systems, adequate household septic systems for rural families, and in less resourced areas, the use of ventilated improved pit VIP latrines. Encouraging communities to build, maintain, and use VIP latrines was a major recommendation to control fecal-oral diseases in our 12 years of community engagement work in East and Central Africa. Generally, VIP latrines cost about $12 US to construct. Maintenance is minimal. As diagrammed, the airflow through the vent pipe not only vents offensive odors, but also effectively draws flies from the pit to the fly screen where they collect and die. Flies can transmit various fecal pathogens to humans by landing on eating utensils and food, etc. Provision of safe water supplies depends on the resources available to a community. For some communities, municipal water systems are possible. For many resource-poor or rural communities, protected wells and practicing personal protection measures are the only reasonable options. Since Cryptosporidium and other parasite cysts, oocysts, and eggs are chlorine tolerant or resistant, additional treatments of water are necessary to inactivate or remove these organisms. A common municipal method is illustrated in this diagram. Raw water is first coagulated and flocculated. Flocculation involves the addition of compounds that promote the clumping of particles so that they can be more easily separated from the water. Coagulation is a chemical process that involves neutralization of charge, allowing the particles to more easily settle out of raw water. Iron and aluminum salts are the most widely used during this step, but salts of other metals such as titanium and zirconium have been found to be highly effective. The water then goes into a mixing basin and then to a settling basin where the flocculated and coagulated particles settle. The next step is usually to fluoridate the water. Fluoridation of water is important to improve the dental health of a population. The water then passes through a carbon and sand filtration process. It then is treated with ultraviolet light, chlorinated, and stored. Often, as diagrammed, corrosion control processes are applied to prevent distribution system deterioration. Obviously, this municipal water treatment system is not feasible for most rural or resource-poor areas of the world. Providing safe water for rural and resource-poor areas can be done. Safe water supplies may be significantly augmented by adequately constructing and protecting a community well as pictured. The well should be as deep as possible and the surface around the well protected with concrete as demonstrated to help prevent surface contamination. Even with these measures, it's wise to boil the water as an extra safety measure. Personal and household measures to prevent cryptosporidiosis and other intestinal pathogens include 1. Wash hands with soap and water for at least 20 seconds, rubbing hands together vigorously and scrubbing all surfaces. Before preparing or eating food, after using the toilet or assisting someone with using the toilet, after changing a diaper or having a diaper changed, after caring for someone who is ill with diarrhea, and after handling an animal or its waste. 2. Avoid participating in recreational water activities like swimming while ill with diarrhea and for 2 weeks after symptoms resolve. 3. Exclude children with diarrhea from childcare or aggregate settings. 4. Avoid ingestion of inadequately treated water, including ice. 5. If the safety of water is questionable, drink bottled water from unopened factory-sealed containers. Use a filter that has been tested and rated by the National Sanitation Foundation, NSF, standard 53 or 58 for cyst and oocyst reduction and removal, or has an absolute filter pore size of 1 millimeter or smaller. Remember that filtered water will need additional treatment, like boiling, to kill or inactivate pathogenic bacteria and viruses. Disinfect water by heating to a rolling boil for 1 minute at sea level. Other home water treatments include flocculation, chlorination, solar, or ultraviolet disinfection. The boiling point of water decreases with altitude, so how long should a person boil water at various altitudes? This is a statement from the Centers for Disease Control and Prevention. So even at the highest point on Earth, bringing water to a rolling boil will kill pathogens in less than a minute. For an added margin of safety, the CDC recommends boiling for 3 minutes at altitudes above 6,562 feet. While altitude changes the boiling point of water, it's not significant enough to affect purification by boiling. This is a statement from the World Health Organization's guidelines for drinking water quality. The process of heating water to a rolling boil, as recommended in the WHO guidelines for drinking water quality, is sufficient to inactivate pathogenic bacteria, viruses, and protozoa. After the water has reached a rolling boil, it should be removed from the heat, allowed to cool naturally without the addition of ice, and protected from post-treatment recontamination during storage. If turbid water needs to be clarified for aesthetic reasons, this should be done before boiling. Householders should combine methods to address the full range of infectious agents. This is particularly important for persons with HIV/AIDS. The World Health Organization, WHO, ranked household water treatment as one of the most important interventions for people living with HIV in low-income settings. International organizations, including the USAID, the World Bank, and WHO, called for an integration of water and sanitation activities in HIV programs. While it is important to address all categories of microbial pathogens, the optimal household water treatment solution requires a balance between microbiological performance, affordability, access, and perhaps most important, correct and consistent use. In summary, Cryptosporidiosis is second only to malaria measured in DALYs in global parasitic disease impact. Cryptosporidium primarily causes diarrheal disease. Cryptosporidium is transmitted mainly via the fecal-oral route, often through contaminated water. Persons with immunosuppression, and particularly those with HIV/AIDS, are at high risk of severe disease and death. Cryptosporidiosis can be controlled by community and personal measures.
Take your public health practice skills to the next level. Our specialized certificate courses give you an opportunity to work systematically through a public health topic and demonstrate your understanding of that material in a capstone project. Learn more and sign up at ndphtn.com/certificates.